Hi, this is Kathleen McCullough, and today I'm reviewing an article on budgeting for EHR implementation. This article was written by Dr. Wang and Professor Biederman and originally published in 2013. I wanted to start off with the background of EHR system growth and where we are now. The article mentions that adoption rates have been slow, but with regulation and incentives, it was expected to increase. According to a national EHR survey from the National Coordinator for HIT, as of 2017, nearly 4 in 5, or 80% of hospital-based physicians have adopted a certified EHR. And since 2008, office-based physician adoption of any EHR has more than doubled, from 42 to 86%. You can see the visual at the bottom for growth. In 2017, also, 96% of all non-federal acute care hospitals possess certified health IT. This comes from the 2017 AHA Annual Survey of Information Technology Supplement, and you can see the bar chart at the top for the breakout of different size hospitals. All of this being said, there are still hospitals and clinics out there that need to adopt EHR systems. The HITECH Act was helping to provide incentives. Meaningful use was established as part of the AMMA Act of 2009, and beginning in 2011, CMS created incentives programs for Medicare and Medicaid providers to adopt EHR systems. Phase 3 actually ended in 2018, and CMS renamed the EHR incentive programs as the Promoting Interoperability Programs, creating a new phase of EHR measurement, which is focusing on interoperability and improving patient access to information. So now physicians who fail to participate actually receive a penalty in the form of reduced Medicare reimbursements. So for those still needing to adopt a system, this article is a great starting point to budgeting. Budgeting is broken down into 3 sections. There's the operating budget, which is your future funds of day-to-day operations. Then your capital budget, which is activities of firm buying and implementation, and that's what this article is focusing on. Then there's your cash budget, which is your inflow and outflow, and can again be affected by a reimbursement that's made by Medicare and Medicaid, depending on if meaningful use is being demonstrated. A survey from CDW Healthcare shows that at the time this article was written in 2013, it cost roughly $120,000 per physician to implement an EHR system. This article gives an example throughout the study of an implementation budget for a small community hospital with 20 physicians, that's including full-time, part-time, and consulting. Budgeting varies widely depending on the size and complexity of the organization, but using this study as an example can help any organization with a starting point. Now, the CEO is who usually sets the overall budget or the baseline, and then it's up to the CFO to break out that budget. In this example given by the authors, the CEO of Hospital A gave a baseline budget of $1,560,000 based off of meaningful use incentives awarded to them by CMS. These incentives may have stopped, but the guidelines and tools for meaningful use are still in place. And then full implementation may cost well over this budget, but if the hospital could implement the main components that was necessary to show meaningful use, then they would be rewarded those incentives. So the first step in capital budget planning is estimating the cost for each project element. So the CEO should do a cost-benefit analysis of the entire implementation project, including your hardware, your software, implementation, training, and human resources. As this is only for the implementation part of the project, productivity loss, shift change, and maintenance aren't taken into account. This article breaks out human resources first because it's the biggest and most important part of the implementation process. Creating a project team that helps create and customize the system needed for the organization is very important for the success of the overall project. So this includes a project manager and the IT staff. The project manager salary is budgeted at $120,000 per year, which is probably average, at least for 2013. And there are 3 full-time programmers budgeted at $90,000 per person per year. So this totals $390,000. Also, as these employees are contract-based, benefits such as insurance and 401k budget is lower than usual, so it's estimated around 28% of their salary because they tend not to take full advantage of these items. Step 2 is the hard costs associated with implementation, which includes Building and remodeling, or making sure all equipment can be hardwired in, so possibly wall relocation, carpeting, installation, and air conditioning, which were examples given in the article. This is budgeted at $250,000. Then there's furniture such as chairs, desks, and workstation, which is budgeted at $50,000. There's software such as licenses, renewal fees, and customizations and add-ons, budgeted at $500,000 per license times 10 months. They've realized that they don't actually need the license until 3 months into the project. So they budgeted at 10 months and 20 physicians, which is $100,000. Then there's disaster downtime process, which is offered by vendors in the event that the system experiences an unscheduled outage. And it includes downtime reporting capabilities from a recent checkpoint. So this comes highly recommended by most vendors and is estimated at $16,000 in this scenario. Your hardware is your computers, servers, networks, and accessories, and these are usually driven by vendor requirements or recommendations by the vendor, so it's always advised to get the most recent and up-to-date hardware to ensure the best productivity. For this size hospital, the authors estimated a need for 3 servers, which includes the main database, and then email and backup and things like that, so it's budgeted at $6,000 each, totaling $18,000. Then there's your network, which includes things like modems, routers, and cables, and that's estimated at $5,000. And your miscellaneous costs, including things like printers, scanners, etc., and that's budgeted at $5,000 as well. So your total for these hard costs are $511,000. Those costs can also vary by negotiations or quality of the product and business relations, so the author provided some estimation techniques. The first one being analog, which is based off your existing relationship with vendors, and they have, quote, the same as last time, which can be used as estimation for things like remodeling and furniture and being careful to maintain those good working relationships. Then there's parametric, which is total cost equaling the unit price of the product times the quantity, also known as bulk pricing for things like servers and computers, hardware, and office furniture. And then there's vendor bids, where the buyer specifies the items that they need and sends out invitation to multiple vendors to bid on that purchase. This is a good leveraging technique, and it can often drive down prices as long as you keep that good business relationship and don't drive it too hard. Step 3 is calculating your administrative costs. You possibly have to adjust your internal resourcing because some staff may not be able to adjust, or they may not want to adjust and to the adoption, and they might just quit or retire. And then there might be some layoffs that are necessary, but weighing the cost of possible litigation may need to be evaluated. Then your external resources for new position in relation to EHR implementation, which is due to conversion and abstraction that are necessary and time consuming. The example given was for HIM professionals that are needed to do conversion work at the hospital because you need to keep records for at least 7 years and then 10 years for immunization records. And in this scenario, the CFO estimates it'll take 2 full-time HIM professionals at $50,000 per year each. Then you also have your supportive jobs, which could be temporary positions, but they're necessary for smooth transitions into full-time use of the system. And that includes your go live support, your production support, and your maintenance support. That's estimated at $40,000. Then you have training, which is including skill assessment, skill training, application-specific training, and go live training. These fees, again, are usually expensive, but very essential because they're suggested to buy as much training as you can afford. And this also is going to cover your overhead, such as travel and lodging for the trainers and missed work for your staff participation. Training's budgeted at $80,000. Lastly, you have your physician champion income support, which is revenue protection for physicians that are championing and advising over the projects, as well as their compensation for time taken away from their practices. That's budgeted at $90,000. Then you always have your miscellaneous cost of $6,000, so this totals $420,000 for administrative costs. Next, you want to aggregate your costs. First, you want to add in a contingency expenditure for any unexpected costs that may arise. 10% was what was recommended per this article. And here you can see the first draft of the budget from the article. This budget's actually over by $13,220 from what the CEO had originally set as the baseline. So for the CFO, they have to go back and adjust. In this scenario, the CFO took away one of the HIM professionals and subbed with interns or students that were $20,000 less. The best way to do a budget revision is to conduct a budget analysis to identify where costs could be reduced, possibly negotiating harder or lowering salaries or examples of cost cutting. But the authors did note that lowering an average salary is one factor that causes dissatisfied workers, and then too much bargaining could cause a relationship to go sour. So you need to look at innovative solutions such as outsourcing, volunteering, reducing monetary incentives for physicians, and then even speaking to the CEO on budget revisions or project scope revisions to help keep the budget on track. Revisiting these budgets and adjusting throughout the implementation process is necessary to make sure everything stays within the baseline. In conclusion, this article was written in 2013, so although scenarios and budgetary process was valid, the incentives and budget scenarios don't account for current market or inflation. Also, this article bases its scenario on a hospital, but the methodology could be applied to a physician clinic or office setting. The baseline budget would just need to be adjusted based on the number of eligible physicians in the office. And then here you can see the resources I used. Thank you.